like everyone can do the audio. We might have some folks connect in a minute or two, but so right now we're here for wellness, substance use and abuse, presented by Ray Daw. It's being presented by the MHTTC, American Indian and Alaska Native Mental Health Technology Transfer Center. As you see on the screen, this is a part of a national network. The regions are presented on the map. And there's always this disclaimer that the content of this event is the creation of the presenters, and the opinions expressed do not necessarily reflect the views or policies of SAMHSA, HHS, and the American Indian and Alaska Native MHTTC. Following today's event, you're going to receive a follow-up email. We'll have a link to the recording, the presentation slides, information how to request and receive the CEUs if they're available, and a link to our evaluation survey that Gimbra will also drop a link to that at the end of the session in the chat. We always like to include a land acknowledgement, and I'll just give you all a minute or two to read this. Thank you. And this land acknowledgement was created by members of our team, Ellen, Keely, Driscoll, and Sean there.
Okay.
And then I think I turn it over to Ray.
Right. Well, good morning, everyone. It's good to have everyone here with us today as we do the seventh in a series of webinars for the 90-day grantees and other partners that we have joining us. These series of webinars is made available to us through the Albuquerque Area Southwest Tribal Epidemiology Center, which is part of the Albuquerque Area Indian Health Board. And Sharpula, who's here online with us, is going to be working with us on the presentation. The mission of the Epidemiology Center to collaborate with 27 tribes across 3 states, basically to provide quality research, health surveillance, and training to improve the quality of life of our people in those across those 3 states, and to have a positive impact on the health and well-being of the communities that the Albuquerque Area Indian Health Board serves. Go ahead, next slide. This is my bio for you to read later on. You'll have access to the PowerPoint as well as the recording, so go to this later. Next slide. Shari, you want to do your bio, please? Introduce yourself.
Yes, good morning, everybody. Charlotte Kula. I'm a clinical social worker by training. I'm Hopi Tewa and Navajo. And let me see how I do. You guys see me? Okay. I'm in Tulare, Washington today for the Tribal Opioid Response grantee meeting. So coming to you from Washington, but my work is at the Albuquerque Area Southwest Tribal Epidemiology Center, which you all know is Aztec. We've had about, I think this is the 6th or 7th in our series of webinars around depression, suicide prevention, today's substance use. We've done some around PTSD, so violence prevention. So this is our last webinar, and I thank you guys for being with us through this entire series. I hope we can do one maybe next year. I know the holidays are coming up and it gets a little crazy with holidays, but thank you for being with us. And I hope you enjoy this last series that we have.
Yeah, I think we have one next week, sure. the wrap-up session.
Oh, we do? Okay. So second to the last, sorry.
No, that's fine. But, okay. We also have, want to acknowledge Dan Foster and his wife. They are co-presenters and co-developers of the content. So they may be dropping in, but nonetheless, if they are not able to join us, they want to make sure that we acknowledge them as collaborators with this process of training and the webinars that we've been blessed to have made available with everyone. So that's Dr. Foster. He's a member of the Lakota Nation out of South Dakota and a psychologist in Montana, as well as his wife. They're both practicing clinicians. Next slide, please. So we have 4 objectives here. The first objective is to have a discussion or a presentation on the signs and symptoms of substance use disorder. And the second objective is to look at traditional approaches that exist to deal with substance use. The fourth objective is to discuss Euro-American ways that exist to help someone who's coping with substance use and abuse. And then the fourth objective is to have a review of resources that are available locally to assist those relatives of ours with substance use and abuse needs. So those are the 4 objectives we'll be covering through. And then at the end of the my presentation, Cheryl will be doing a case study with us. It's beautiful case studies that she's been putting together. So thank you for that, Cheryl. Next slide, please. Signs and symptoms of substance use disorder. This is basically a review of the DSM-5 and the DSM-5-TR. The DSM-5 was modified recently and is now officially known as the DSM-5-TR. And in that modification, there were a few changes that were made from the DSM-5 to the DSM-5-TR, but there weren't really substantial changes made to the what is called the substance use disorder. One thing that happened in the transition from the DSM-4 to the DSM-5, DSM-5 is the removal of substance abuse and substance dependence as disorders. So that was a significant change from 4 to 5. And then another change that was instituted and is within the diagnostic system is a severity scale, which is basically mild, which means presentation of 2 to 3 symptoms, moderate, which is a presentation of 4 to 5 symptoms, and severe, which is a person presenting with 6 or more symptoms within the diagnostic criteria that is set for substance-related disorders. And so the DSM-5-TR did not have an impact on changes that have been made earlier. Next slide, please. If you can in chat, maybe you can present who you are, where you come from, and if you are tribally affiliated, description of tribal affiliation. I see Bohan Hinani. Well, that's Sanina doing that already from Chicago. So what does it look like from the DSM-4 to the DSM-5? As I mentioned earlier, there are some changes that happened. And basically, this chart shows how those modifications compare to each other. You can see that I'm imagining that most of you are clinicians, so this is probably something you're aware of. Next slide, please. Going on to the changes from DSM-4 to DSM-5. And you see the scale on the right side. The presence of 4 to 5 symptoms to be diagnosed as having moderate substance abuse, and then severe with 6 or more symptoms. So those are the symptoms that are laid out. They're described quite a bit differently. Next slide, please. What is the criteria for what is the DSM-5 criteria for substance use disorder? Well, here's the criteria for substance use disorder. This comes out of the APA. Basically that when at least a person has to present with at least 2 of the following characteristics within a 2-month period, and that cause significant impairment or distress. One is to have, of course, the quantity of substance use or the amount of time spent using is greater than intended, which is sometimes called loss of control. And then one of the other characteristics is unsuccessful efforts to control. And then the person spending considerable time using the substance, recovering from the effect of withdrawals, for example, and attempting to and going and getting it again. Craving. One of the changes is that craving is identified as a characteristic of substance use disorder. In the DSM-4, that didn't exist. So that's one of the significant changes, is acknowledging craving as a symptom. And then basically the list goes on. Interpersonal effects, interference with work and school, and basically life. And a person who avoids or reduces their activities outside of their home, and then when someone begins to put themselves at risk of risky behaviors. So that's another thing that happens. Next slide, please. Some of the addictive disorders which are identified at DSM-5 are these addictive disorders: alcohol use, cannabis, hallucinogen, inhalant, opioids, sedative, hypnotic use, stimulant use. And what you see in the highlighted areas are some of the changes that happen from and mainly nomenclature, I guess, or naming of or description of what these disorders are. There's tobacco use disorder, and one of the things that's interesting is the identification of unknown substance use disorder. So this is a listing of some of the addictive disorders from the DSM-5. DSM-5 TR didn't change any of this really. Go ahead, next slide. So that's our presentation on the diagnostic manuals approach to how we identify or begin to approach problems that a person may come to us with a disorder that's coming from misuse or use of different substances. In the traditional way, there are traditional approaches to deal with substance use. The traditional approaches are very tribally specific generally, except for probably the Native American Church, which is more globally intertribal. And so there's the approach that is there is to basically begin with grounding relatives who are affected by substance use and abuse with blessing, prayer, and offering. We have in the Navajo way, one of the beliefs we have is that when someone has difficulty collecting the thoughts and behaviors that are associated with that, and difficulty having less control over their lives, one of the approaches that we have is use of traditional tobacco. It's called titnalier, or putting things to becoming centered in our thinking and having clarity in our thinking through use of mountain tobacco by making that offering with the mountain tobacco. It's not uncommon for in the Navajo system, in the prayer process that comes with use of mountain tobacco and the songs that come with it. In many of our tribal ways, songs and prayers are done together. In Navajo, if you see a Tashi, a healer, Navajo healer, they'll often begin a prayer or ceremony with a song or two, or several sets of songs, depending on the length of the ceremony. Then they'll go into a prayer as a way to acknowledge the difficulty a person might be having, and acknowledge that the person is seeking a healthier way of being. So the prayer, what is described as prayer here, it can be a complicated system. It's not just saying a prayer, but also includes oftentimes use of songs prior to, in the Navajo way, we end our prayer ceremonies with other songs. And within the tobacco ceremony subset, I call it a subset, with our specific songs that are sung in conjunction with smoking medicinal tobacco. And so it might seem like the use of the word prayer is well, to me, the use of the word prayer is an oversimplification of what happens in many of our traditional ways. Within the NAC system is fairly similar, the Native American church system. You see a roadman and they'll do a song, and then they'll do a prayer to lead into how to ground. Many Native American church ways include in the ceremony some talking, the discussion on diagnosis and offering of how to seek help. And these prayers are basically done to attain mindfulness, to become more mindful of where we are and how, in this case, these different substances might be affecting our lives and our behavior and then our thinking, because that's kind of how most Native systems work. Is I believe Native systems are very cognitive behavioral and design and processing. So this is how the traditional approaches are sometimes occurring with substance use. And many of our systems are herbs that are made available to patients so that they can begin to work through the problems associated with craving or the problems associated with withdrawal. Most traditional healers are very in tune to being conscious of how severe a patient's withdrawal might be. If a person has real severe withdrawals, and they'll be very careful about what they will and what they won't give a patient as part of a ceremony or as things to do after a ceremony. So that's one of the ways to do it. And in most of the tribal ways, are people who make that decision to work on changing their life will often be given sage or cedar or other ways to continue offering blessing and offering ways to get clarity of their thinking and to stay grounded and motivated to make the kind of changes in their life that he or she may be working for, and the family too. So this is a description of how traditional approaches can be applied with relatives who are affected by alcohol and drugs. And a lot of discussions around traditional approaches, a lot of attempts are made to talk about ceremonies. In these series, I've made a decision to talk about the impact of ceremonies and some of the processes that are involved within traditional approaches as a way to share our understanding of how our ways are. I'm personally a practitioner or learner, right, I should say, of the Navajo traditional ways, and have seen how Navajo traditional practice are done, and how traditional healers work at applying their skills and knowledge with relatives. Next slide, please. So what are some of the traditional approaches that can be applied? I mentioned earlier the mountain tobacco ceremony and the Navajo system, and other systems that exist across Native country. If it's addictive behavior that might be because of grief, there are ceremonies to begin to ground a person after prolonged grief, and like the wiping of tears ceremony in the Lakota way, the Navajo system. We have a number of ceremonies that are intended to resolve the complicated effects of grief and mourning, and it often appears to many of us who practice traditional ways that many relatives have experiences of being alone or having experienced death or separation from family members or significant others. Those tend to trigger problems with drugs and alcohol, or having uncertainty about how to live, create a good life. So those are some of the traditional approaches that can be there. And I know in urban communities, one of the traditional approaches that's heavily applied are talking circles, which is adopted from a tribal way, but also the Squat ceremony, as well are some of the traditional approaches that are applied, and then the use of smudging with cedar, sage, sweetgrass is often applied as traditional approaches that begin to ground relatives who are affected by drugs and alcohol. And that's been a nice thing to see across Native country over the last few years, of this greater adoption of some approaches that can be applied intertribally. But still, we have to be sensitive that not all tribes practice the same way or the same ways. For example, there are tribes who don't use the sweat lodge, for example, and so there's something to be always aware of. Clinically, is when we have a person who begins to express a traditional approach as a desired way to kind of assess what those ways are, and asking questions about their comfort or their tribal values around certain practices that might be there. Like in the Navajo system, we use corn pollen. A lot of tribes don't use corn pollen, but a good portion of the Southwest tribes, particularly in New Mexico, use corn pollen as a way to as a traditional approach to have clarity and to be mindful of how our lives are. So that's a good discussion of what traditional approaches can be applied. Next slide, please. One traditional approach that most of you, if not all of you, probably are aware of is the wild variety approach, which is developed by through the white bison folks up in Colorado. I include this as part of the subset of traditional approach because wild variety has become very well adopted across native country. And consequently, we have a lot of discussion, a lot of presentations, and a lot of incorporation of wild variety teachings into different service delivery systems, all the way from all across the lower 48 and all the way up until Alaska. So it's wild variety has become a very well accepted approach to a traditional approach that is not tribally specific, but is grounded on the intertribal values and intertribal ways of teaching. Use of the drums very strong. The healing circle, for example, is another one really strong. The nice thing about the wild variety is that the wild variety system, because it assumes that there are teaching ways that are adopted for families, people, communities. And so it's been a really nice movement for many of our people who are not attached to or grounded to specific tribal ways. And so this is something that I felt was important as part of the traditional approaches that we work with and that we acknowledge and that we have access to. Fortunately, the White Bison does a lot of webinars and trainings on wild variety across the United States and accessed. And if you have a chance, go to the White Bison website if you're interested in learning a little bit more about wild variety through the webinars and conferences and on-site training that they provide. If you have any questions along the way, of course, you can present them in the chat, and we can get a review of them later on. Next slide, please. Now, what are some Euro-American ways of helping people? The Euro-American ways, as well as the native ways, basically work at instituting values that are different from, it's a very cognitive approach. Many of them are values different from a substance abusing lifestyle or an addictive lifestyle. To have support, to have someone who's being troubled with substance, drugs or alcohol, to begin to acknowledge affection, love, and to have a future-oriented approach, and to become grounded, resilient, in a way that they can be a good friend and a good relative, and according to the way our tribal systems are developed, and to have kindness, and not only to others, but also to have kindness to themselves. So this is some of the common ways that are there in the Euro-American system. Next slide, please. I thought it'd be good to show what is described as the top 10 most abused drugs in the United States. We're aware that alcohol is number one, but they kind of rank out like this. They show up like this: marijuana, painkillers, of course, and then cocaine, heroin. You can see the list go on to meth. These are the drugs that are more common in American communities, but also in the Indian country. So this is the challenge we have, that there's a whole array of substances that are abused, and they have different impacts. You know, someone affected by alcohol abuse, or as you probably a lot of you know, will have symptoms that are different from someone who's presenting from stimulants, for example. And that's a challenge clinically in terms of working on assessing and working on treatment planning. And then we have this problem of polydrug use as well that is occurring, seems like a lot more frequently these days. But as we try to adopt ways to have a service delivery system that is effective for our people, you end up, the nice things we end up growing, I think, as a field in behavioral health to understand these impacts that these drugs and substances have on our relatives. Next slide, please. Now, what resources are available to assist our relatives and families affected with substance use and abuse? And this is where some of the nomenclature begins to change from the DSM-5. You know, the DSM-5 talks about substance use disorder, alcohol use disorder, and so forth and so on. But in the nomenclature begins to change, because one of the most widely adopted resources for substance use and abuse are 12-step programs like AA. I don't know of any. There are very, very few providers, either agencies or individual providers, who don't apply AA as part of a intervention or as part of treatment. The 12-step system is incorporated into a whole number of ways, like NA, Cocaine Anonymous, and the list goes on. Basically, these self-help groups, support groups, are designed looking at, in this case, like alcohol as being, that's where the nomenclature changes, where 12-step incorporates, making acknowledgement that we have lost control over either alcohol, narcotics, cocaine, or meth, and that loss of control and acknowledgement of loss of control is a big part of how these 12-step programs work. That's basically step one. And with an AA, as a lot of you know, it says acknowledging, as a person acknowledging that they're an alcoholic. So that's a self-identification that occurs as part of that system. Within the DSM framework, the use of alcoholism is not common, because you don't see that in the list of symptoms. So this is, I always have to acknowledge that 12-step programs are built into our behavioral health design and will always be there. And sometimes it's a little bit, sometimes not exactly in step with the way DSM systems are working or are worked. But nonetheless, they're there and incorporated into drug courts and wellness courts and veterans courts, and a whole myriad of interventions that are out there. Next step, please. Next slide. One of the focal points of a person beginning to become grounded towards life-changing decisions to move away from a substance abusing way of being is to have a whole array of teachings and systems available. One of the grounded aspects of your American system is medication. Someone who is physically addicted to a drug of any kind, alcohol or anything, will often be given medication as a way to address the withdrawal problems that happen, and to begin to medications also used to address the craving problems that happen. That's part of that withdrawal and recovery process afterwards. Street drugs are so prevalent these days, like fentanyl, that it's really become a lot more difficult, I think, for our relatives to not be influenced by peers and relatives and other people in the communities who push drugs and alcohol. But one of the good movements, I think, in the field that we're in is the adoption of peer support programming and systems and the work that we do. I know in many of the communities, there's a greater application of peer support as a way to begin to get recovery going. Recovery is a word that is often applied, and to begin to have stronger support for relatives that are affected seriously and severely by substance abuse, and to begin to change relationships and how we take care of ourselves. That's my laptop, excuse me. It's going crazy on me. So, next slide, please. I see Sanina, I should say, mentioning a conference coming on September 14th through the 17th in Colorado Springs. And there's a link if any of you are interested in joining. It's Serena. Okay, sorry, Serena. There's a link for that conference that's going on, the Wellbrighty Conference. So thank you for that information, Serena. You can click that and see if you're interested. What does all this wrap up to? Well, I think that it seems that as 988 program people or providers who are working to develop mental wellness with our relatives, is a teaching that is very grounded from within the Navajo system, that life is beautiful, and that our lives are created to be celebratory, to be able to celebrate and acknowledge that the world we live in has a lot of beauty, and the world we live in has within it a whole myriad of relationships that are good, and also acknowledging that there are relationships out there that are not good, that are sometimes not healthy, and to begin to be very conscious about how we live our lives, but the grounding principle in the Navajo system and all the systems that are out there, I think, is to have a person who is substance abusing begin to turn from a life that is harmful, from a life that is, from our value systems at least, not beautiful, and to begin to have a healthier life physically, mentally, emotionally, and spiritually. it's the spiritual practices that exist within traditional ways that are, I think, grounding for a lot of folks. And within this section, I think is valuable to point out there are studies that show that among Native people, we have a higher proportion of folks who are abstinent in comparison to other populations across the United States. And this is really major, for me, it's a major teaching tool. It kind of moves away from the misperceptions that are there, that a disproportionate number of our relatives are living lives that are addictive and living lives that are unhealthy. We're seeing, there's, I think, a strong movement across Indian country more and more to help each other out and to have ways of teaching that acknowledge happiness versus sadness, for example, to be positive thinking forward and to be able to help each other that way. And the 988 system, I believe, is one of those first steps towards being available for someone who is beginning to have some thoughts about reaching out and have some thoughts about how to manage life in a way that is different and well, not only for themselves, but also for family members. And a growing part of the behavioral health system, I'm seeing behavioral health providers take the 988 number and begin to apply it in not only intake, but apply it as a part of intervention. And it seems that a growing portion of peer support people and clinicians are reaching out to clients and patients and offering 988 as a strong alternative to when someone is wanting to speak to someone about the personal problem that might be related to substance abuse. In New Mexico, for example, we have the program that's out there. As part of the 988 program, we have the state reaching out to offer support to people who are affected by missing relatives. So there's a new initiative in New Mexico to have that kind of support available for family members and people who are experiencing grief as a result of a family member missing and not being around, but also for people who have become missing and have trauma-related emotional and cognitive problems that sometimes they have difficulty talking about. And so the 988 system has become adaptive that way, as well as for veterans and other subsets of our population. So the teachings around life is beautiful, I think, is becoming sustaining for our relatives as we look at how to build a 988 system that is impactful for our relatives and our family members. And so one of the things I do, for example, when I'm out in the community and talking to relatives, is I'll take my cell phone and I'll dial 988 with a relative standing next to me, and I'll say, this is what it does. And I'll actually show them or have them listen to how a 988 response occurs when you dial those three numbers, and work through work through what happens when you call 988 and someone answers the phone on the other side and begin to have a discussion on a phone. So it's one of the common things I do in my work as a behavioral health provider and primarily New Mexico and Arizona. So I'm one of the ones who strongly believes that if we adopt 988 processes into our work, that it can be meaningful and helpful to our relatives. In this particular slide, there are a number of tools available to all of us on a website, we have a Facebook page, for example, that we can look at, be able to draw down literature, and be able to have support for each other. So this is a nice feature. 988, you can call, text, or message, and the more heavily used part of that those three ways is to call, and a lot of people call. And fewer people are messaging, but then it seems that we're seeing a growth in the proportion of people who are texting 988 as a way to reach out for support. So as the system evolves and we end up building on it a little bit more, because we're barely a year and 2 months into the 988 system, I think we'll see stronger effect by it. So this is how the 988 system can be designed and can be worked. Next slide, please. And we have the case study. And from here, I'll turn it over to Shar. Shar.
Good morning, everybody. So with this series, we all like to do a case study afterwards just to assess knowledge and then to see, so first of all, I'd like to know, what are the signs and symptoms you see in this case around either substance use, maybe some mental health disorders are occurring, what's going on with relationships. I'm a social worker, so I always think of it as a psychosocial. I know some are maybe counselors and substance use counselors, so we're all going to participate. There's, I think, maybe 8, 10 of us online. So I'll go ahead and read the case study, and then I'll ask a couple of questions. So Jim is a 42-year-old male who separated from his wife of 18 years. They have 2 children, 13 and 16. Jim works in finance for his tribe, and his wife is an elementary school teacher. Jim lost his mom 4 years ago to cancer, and his dad died 6 months ago from a heart attack. He has an older sister he's not close with, and they have to clean their parents' house, and he's constantly avoiding her. Jim used to drink beer with friends, but now it's more liquor he's consuming. He often misses work on Mondays and is constantly late. And he's on probation at work for missing too many days and has to go to substance abuse counseling to keep his job. He feels he has no problem and his boss is being unfair. His wife does not care about him and the kids do not listen or respect him. He's tired of trying and wants to look for a new job. When Jim is stressed out, he smokes marijuana, drinks at home with cousins and other relatives and friends. Recently, his cousin gave him fentanyl to try, and he did it at least twice. His wife has moved to town with the kids because it's close to her job. When Jim gets intoxicated, he argues with his wife and kids, and they end up leaving anyway to go to town to stay with relatives. Jim was recently diagnosed with diabetes and is not motivated to change his behavior. He isolates himself, is angry, and does not want any help. So in your opinion, what do you think is going on here? Just in general, let's not think about signs and symptoms yet, but in general, what do you think is going on here with Jim? Oops, my phone, sorry.
He's dealing with loss. He's dealing with loss.
He's lost, and what'd you say?
I'm getting feedback. He's dealing with the loss of his parents.
Yeah, grief.
Loss. Yeah.
And then to lose 2 parents within a 4-year time frame, that must be impactful, right?
I can't even imagine, yeah.
And then to go and clean his parents' house out. Like, I think I would probably avoid that too, and do it with the sister you're not getting along with. I hear from Mitzi Lee that he's depressed, doesn't know who to reach out to. Yes. What else do you think is going on? There's something else going on. What's going on with a couple of relationships? I know you guys are out there. You can put it in the chat too. What else is going on with some of the relationships?
Whether it's the separation from the wife. And that
Separation.
and that loss of the family structure in his life.
Yes, the kids, he thinks the kids don't respect him. Some of his family and friends are supporting the substance use. He's avoiding confrontation with family. Yes. So a lot of relationship stuff going on, would you say? Thumbs up.
Thumbs way up.
Okay. Now let's look at some of the signs and symptoms of what's going on. What else is going on here with Jim?
His work life is particularly it's in disarray, or he's not really
He's on the verge of losing it, right? Losing his job.
yeah.
Yeah, he's on the verge of losing his job. He's separated from his wife. He lost his parents. His kids, he feels are not listening to him and respecting him. He's isolating from the community. Yes. So we got relationships. We've got signs and symptoms. We've got the job. What else is going on if you look at that third bullet point? Okay, his alcoholism is getting worse because it's not beer no more. Yes. And now it's hard liquor. And so remember that one slide that Ray showed us from mild, moderate to severe? You know, maybe it was just beer in the beginning and now it's liquor. And now, you know, he's separating from his wife. His support system is dissipating, if you will. And also his liquor, the severity is going up a little bit, maybe from moderate to severe. I don't know how much he's doing this, but there's another thing he's doing besides drinking liquor. What was the other thing he's doing with substance use? What else is going on? Now it's fentanyl. Yeah, now he's tried it at least twice. I know marijuana is legal in most states, but it's still a drug, so to speak. So he's now drinking liquor, marijuana, and has tried fentanyl twice. And so would you say his substance use is mild to moderate, moderate to severe? What do you guys think? Moderate to severe, Frankie. Okay, so it's getting up there.
Yeah, there's that phrase that says when Jim is stressed. So that kind of leads us to think, well, it's not all the time, but just kind of as a stress reliever kind of thing.
Yeah, a stress reliever. There is what I forget the word, but like, you know, no more than 2 drinks in a setting, or no more than 2 drinks a day, or within a week. I forget what it's called, like casual drinking, right? When you're out with friends or something, but not to do it on a daily basis. Then it becomes a problem, an issue possibly. But with here, we could see relationships are changing, his job, which provides money so that he can, have a living. And then he's got the substance use going on. And then he has a group of relatives who are supporting the substance use, right? And Mitzi Lee was saying that maybe it's moderate, but it's starting to get severe because he's only used fentanyl twice, but it could get worse. Yes. And we all know the opioid crisis that's going on right now. New data out of our epicenter has shown that there has been an increase of fentanyl use among American Indians nationwide. And that the story goes that it really has increased more on the East Coast and a little bit on the Midwest. And now it's gradually going towards the West Coast. So we're seeing the increase. And fentanyl, as we all know, is like any other drug, is very addictive. And so thankfully, there's something else going on here. What is his job making him do to keep his job? What is going on with his job?
He's got to attend substance abuse counseling.
Yeah, so at least there's some of that going on so that he can understand his behavior, but also there's another medical condition going on too. What else is there going on?
The diabetes, and that is something that speaks to me in my life as I'm trying to get my weight under control, because it is really a disease that will take over. And I'm shuddering thinking about the battle he's going to have if he doesn't control, these things going on in his life. Even the stress with most medical conditions is enough to, send you into a level of.
Yeah, so the diabetes just complicates it all, right? Because then you immediately do have to change behavior to remain healthy. And so it's like, which one does he tackle first, right? There's the grief and loss, there's the relationships, there's his job, and then now there's this diabetes and then the substance use. Can you see how all of that can be complex and complicated and intertwined? And as a counselor, how do you start teasing out all this stuff? In your opinion, how do you start teasing all of this out? I know you guys have the answer. Take a chance. How do you think he can tease some of this out if you were working with Jim? I was thinking of one thing like rapport building, right? That's obvious for the first couple of sessions. What are some of the resources Ray talked about that could assist Jim? Started with the W. Do you guys remember that?
The
Wellbriety, right?
what's the word again? The
Wellbriety.
variety, yes.
Yes. So resources that can help him connect to, just how do I maintain sobriety? Sobriety recovery is a wave, right? It's like you could do so good for maybe 5-10 years and there might be a moment of relapse, but it doesn't mean that you can't get back on recovery. There was a minor setback, but the point is to always have someone you can talk to, either a peer support worker, your sponsor, someone to assist you so that you maintain that sobriety, so that you can deal with all the issues that are going on in life. Because as we all know, life is complicated and sometimes things seem to be coming all at once. And we have to learn how to pick at it and see what we can really addressed and what are some things we can't address. And so hopefully through substance abuse counseling, he's able to tease these things out and figure out which one he wants to work on. Some techniques that as providers, you probably already know is like motivational interviewing, right? Just hearing the individual, joining the individual, helping them figure out solutions to the issues they're dealing with, but really having them talk and tell you their story and really identifying what other support systems do you have in your life so that you can rely on them as you go through these steps of mending relationships, possibly finding a new job, maintaining sobriety. And so how many have you had similar cases to this where there were those complex issues going on? Can I see a raise of hands? Well, sobriety is good, but Jim has to make a choice to be sober because if he's not motivated, it will be hard to get him on the road of recovery, which I run into with a lot of men. Yeah, you have to be committed, right? You have to be committed to that sobriety walk. And sometimes some people aren't there. That's why MI starts wherever they're at, right? Maybe he just needs more education and resources. Now with him having diabetes, maybe that will make him think twice about reducing the drinking at least, or maybe stop the liquor consumption. But everyone's on their own journey. Everyone takes it at their own pace. So we just got to start where he's at. Any questions about this case? You all are quiet this morning.
Yeah, what the
Ray,
body says he does not want help. So how do you deal with that?
I have a recommendation, but let me hear from you. What do you guys think? If he doesn't want any help, how do you engage him? How do you maintain that engagement? No one? You can write it in the chat too if you want. I'm just scrolling through names to see. Thanks for asking that, Stephanie.
My pleasure.
It says you don't give up on them because if you stop caring, they will think you never really cared. You're right. So it's really starting with them and figuring out what are their interests. What is it that you like to do? What is it that you stop doing? What are your support systems? Figuring out like what they like to do and maybe gradually recommending, hey, maybe you want to start that up. Like maybe for Jim, it was like, okay, I like to, take a walk in the morning and say my prayers, or I like to give my cousin a call in the morning when I have my morning coffee. I don't know, I'm making some stuff up. And those things stop because he's not feeling well in the morning because he's been drinking the night before. And so maybe that one of the things is, why don't you not drink so much the night before and maybe take a 5-minute walk that next morning, or just, little steps along the way to kind of get him going. Because like Mitzi said, you have to start where they're at, but you also want to know that you can't give up on them. And that it's going to take a while for him to get to a point where he sees the drinking is impacting his other relationships and work. Anything else about this case study that you had questions about?
I know at the clinic where we work, we're really zeroing in on diabetes care because even in the best of situations where people are don't have these kinds of stressors, it's really hard disease to manage. So I'm hoping that that's going to be a part of what he does. And the immediate intervention I think that he does is probably going to be the best, give him the best outcome, because like I said, it's a disease that has to be managed. I lost a sister 5-6 years ago, and it has to be managed.
You're absolutely right. It does have to be managed, because if you're not managing the diabetes, the medication, it could progressively get worse. So definitely having to change diet. And so sometimes with medical conditions compared to mental health issues, most folks are readily maybe motivated to deal with, okay, let me address the medical issues over the mental health issues sometimes. So you're bringing up a good point, Stephanie, that the diabetes does have to be managed, and he has to address that. So hopefully with Jim, that might be one motivating factor, is maybe start with the diabetes first. There's a couple of ways he could do this. The point is really to look at how can we tease it apart to assist him to start working on changing something in his life, at least a little bit of something. So diabetes might be the answer. Any other questions about this case study? No? You guys are quiet. Well, Stephanie, thank you for the feedback. Mitzi Lee, thank you for the feedback, as well as I'm trying to scroll through this thing. Not so techy. I think Frankie. Thank you guys. Thank you for talking with us this morning. As Ray had said, we have one more session, and that last session, Ray, what was the title of the last session?
The last session is a wrap-up, kind of overview, review of this session and the other 6 sessions that we went through. And so if you scroll down, next slide, Parker. This is what the last session is going to be. It's a closeout. And to have a broad discussion of the strengths of the community and the power of cultural teachings and how to incorporate that into what we do. This will be the discussion for next week. So next week's that last session.
So these trainings are the 4th Tuesday of every month from 9 to 10:30 Mountain Standard Time. So that will be our last closeout. So if you guys have any questions, I know these are recorded, so I believe Ray has access to some of that information. But I thank you guys for spending time with us this morning.
Yes, very good.
Excuse me, sorry. Hi, Ray. How are you? Just had a quick question with the slide. August 25th is the last day, last session? Oh, okay. So
Yes.
it's this Friday coming up, not Tuesday.
Yeah.
Pilame, thank you so much for today's session. Both of you appreciate it.
And yeah, welcome and thank you everyone for joining today. And I guess we get to have 15 minutes of extra time to us today. Okay. But everyone take care of yourselves, enjoy your week, and you know, let us know if you have any questions afterwards. You have our contact information, and we're more than happy to. And this happened a few times, sure. I've had people contact, asking follow-up questions or asking for different kinds of support. So I've been able to sustain connection with folks afterwards. So with that, thank you. Closing words, Char.
Thank you all for this wonderful morning. I just wanted to share, I told you earlier, so I reside in Albuquerque, New Mexico. I'm in Washington. It is so green out here. I didn't realize how much I missed the greenery. So I hope you guys have a good day. You get to go outside and, as my nephew says, go smell the earth ant. empty, so I don't get to go smell the good air out there. Welcome the morning, he'll tell me.
Mm,
So I hope you guys have a good day.
all right.
Have a good
Thank
day.
you
all.
very much. And thank you for your help, Parker. Couldn't have done this without you. Bye-bye, everybody.
Bye-bye.
Bye.
Mhm.